Hi, this is Dr. Larry Phillips, Director of Nuclear Cardiology at NYU Langone Health. Joining me for today's interview is Dr. David Lewinsky, former President of the American Society of Nuclear Cardiology and Head of Nuclear Cardiology at Cleveland Clinic in Florida. We're going to be talking about the Refer Wisely campaign and a discussion of nuclear cardiology, appropriate use criteria, and advances that are being made to make sure we're improving the value and quality of care that's provided to our patients. David, thanks for joining me today for the first of 4 interviews.
Oh, thank you for having me. It's a pleasure to be here.
So the first thing we wanted to talk about is value and how value in testing relates to the practice of nuclear cardiology.
So we've been trying to analyze the value of testing for approximately 25 years, since the original article by Frybeck and Thornberry in 1991. The first way to assess a test is whether it's technically effective. Can the test be done accurately, easily, and repetitively? The next definition of value is it have diagnostic accuracy. What is the predictive value of the presence or absence of disease? A lot of Bayesian analysis goes in to define whether a test is diagnostically accurate or not. Once we've helped determine whether this leads to a diagnosis, does it really help us decide what needs to be done? How do we incorporate these test results into our clinical decision making? Does it lead us to a test? Does it lead us to one form or another of therapy? Once we have applied these therapies, we really need to understand, is there therapeutic efficacy? For instance, if we do a coronary angiography, can we find a lesion that we could carry out percutaneous intervention on? Will an abnormal test lead us to another test, or do we simply find a disease for which there is no treatment? And finally, is there outcomes efficacy? Does this test lead to better outcomes? And although for a long time that's really where we stopped, we cannot help but really talk about the societal benefit at this point in time, population management. Does doing this test and the treatments that come out of it lead to better population health management? And that's one of the hardest issues for us to solve when it comes to cardiac testing.
So how does nuclear cardiology hold up, and nuclear stress testing specifically, when looking at these areas?
So I think myocardial perfusion imaging actually holds up very well and really has demonstrated that it fulfills all the criterion to be a valuable test. As we know, for the last 20-plus years, we have strong diagnostic and prognostic value. The test is safe and useful to be carried out with exercise or with pharmacologic stress test in a variety of populations, as opposed to coronary CTA, which may be limited by heart rate or renal function or contrast allergy. We can carry out myocardial perfusion imaging in just about any patient population. It's been validated in high-risk subgroups such as diabetics, such as the elderly and the post-myocardial infarction patient, and it's really most useful in the intermediate to high-risk population. There's a strong database that correlates the abnormalities seen on myocardial perfusion scan and the risk of both coronary death and myocardial infarction. One of the landmark papers, Hakamovich from Cedars-Sinai, showed a very strong linear relationship between normal, mildly abnormal, moderately abnormal, and severely abnormal scans in terms of event rate per year. In both cardiac death and myocardial infarction, there was a significant increase in risk, particularly when scans were severely abnormal. And for patients who had a moderately abnormal scan, there was an increased risk of cardiac death associated. So not only can we assess these scans qualitatively, but we can actually assess quantitatively the amount of ischemia that we see on the slides. And in fact, we have a well-established benchmark of 10 to 12% ischemic burden. In a large retrospective study of over 10,000 patients, it has been shown that those patients who have ischemic burdens of less than 10 to 12% can be managed better with medical therapy, whereas those patients with larger ischemic burdens can be managed with, or should be managed with, revascularization. And this has really led to definitions of who should go on to coronary angiography based on the results of the myocardial perfusion scan.
And this is information now with more recent studies that will be investigated further, such as the ischemia trial, to see with modern technology whether or not that fact continues to hold. Another thing that we've watched is over the last 20 plus years, the trend in volume of stress myocardial perfusion imaging that's taken place. If we look back in the 1990s and late 90s, there was over 10% year-over-year growth, with a continuation growth of over 6% year-over-year into the mid-2000s. The question that's often asked is, were all of these tests appropriate?
So obviously, when you do a lot of diagnostic tests, you will have a significant number of abnormal tests that will lead to a next level of treatment. In the case of coronary disease, an abnormal stress test leads to diagnostic coronary angiography. And another landmark study by Patel reported in the New England Journal in 2010, it was clear that there was a low diagnostic yield with elective coronary angiography. Now, we're not referring to patients who present with unstable angina or acute myocardial infarction, but patients who are presented for an elective study when only 37% of these patients had obstructive coronary artery disease. And that led many in the field of cardiology and in the world of medicine to begin to question, is there a better way to decide who needs to have stress testing and who should go on to coronary angiography?
So there's been a lot of discussion about the use of decision support tools and incorporating them into clinical practice. The American College of Cardiology Foundation, the American Society of Nuclear Cardiology, as well as other organizations, have been advocating for the use of appropriate use criteria. There are several reasons why it's important to develop appropriate use criteria and utilization in clinical practice. A couple of key points are first, that literature, when possible, was used to help in determining the gradation of appropriate use criteria. It was developed by physicians and providers, initially focusing on cardiac imaging, although since that time has expanded to other cardiac and other testing. It allows us to serve as a focused reduction of the procedures by utilizing clinical value, not just indiscriminate volume reduction. It allows individual determination of test appropriateness, but also allows there to be a discussion between the patient and the provider to determine the right test for the right patient at that time. So, David, what is an appropriate test?
So the ACCF actually defined what an appropriate test was, and this can be really applied to any procedure. So an appropriate diagnostic or therapeutic procedure is one in which the expected clinical benefit exceeds the risk of the procedure by a sufficiently wide margin such that the procedure is generally considered acceptable or reasonable care. Now, when we look specifically at diagnostic imaging, these procedures provide incremental information which, when combined with clinical judgment, augments efficient care. These benefits are weighed against the expected negative consequences, such as the risk of radiation, the risk of a misdiagnosis, the risk of unnecessary procedures which may cause side effects. And it's this definition that has been perpetuated through the various appropriate use criterion. So the first appropriate use criteria were published in 2005 and were specific for cardiac radionuclide imaging. Subsequently, appropriate use criteria were developed for multiple imaging technologies. And then in 2009, the American College of Cardiology reevaluated most of these criteria and came out with an update for cardiac radionuclide imaging. Over time, it became more appropriate to assess all of cardiac testing by disease state. So in 2013, the multimodality appropriate use criteria for the detection and risk assessment of stable ischemic heart disease were published. And these address a variety of non-invasive testing for coronary artery disease, including myocardial perfusion imaging, exercise treadmill testing, coronary calcium, coronary CTA, CMR, and exercise stress echo. And with the application of the appropriate use criterion, we can actually see that care has been improving. Kaiser published a very important publication in JAMA in 2014 when they looked at the incidence of myocardial perfusion scan from the years 2000 to 2006 and compared it to 2006 to 2011. The latter group was noteworthy for approximately 50% reduction in the annual rates of myocardial perfusion imaging. This, in fact, was associated with a 27% decrease in incidence of myocardial infarction without an increase in stress echo and only mild increase in coronary CTA. So what this means is we began to focus on the care of the patient and not simply deciding whether or not a patient needs to have a specific test done. And this led to much, much better results.
Amazingly, even with the first appropriate use criteria being published in 2005, over 10 years later, a look by the American Society of Nuclear Cardiology found that the knowledge base of providers as well as referring physicians was low as far as understanding the appropriate use criteria, and that there were tremendous deficits in knowledge that needed to be addressed. That is one of the main pushes that led to the Refer Wisely campaign, as well as the collaboration that you're leading between the American College of Physicians and the American Society of Nuclear Cardiology to improve the knowledge base of referring physicians. Can you talk a little bit about Refer Wisely and what the goals are?
So Referring Wisely was developed approximately 3 years ago as an initiative of the American Society of Nuclear Cardiology. The purpose of it was to educate referring providers on the value of cardiac testing, not simply to look at a list of tests that could be done and check one off, but really begin to understand what the patient wants to know, what questions the clinician needs to ask, and how to best order the tests. We've done this in a variety of forms. We have developed approximately 12 case studies thus far that involve a nuclear cardiologist discussing a clinical case, followed by further discussion by a member of the American College of Physicians who gives input from an internal medicine point of view. We have a variety of social media programs that allows access to our information, and we're now beginning a set of podcasts that are both audio and available online. We're in the process of linking directly with multiple societies. That is, we're bringing the cases and the information to the clinician. And so what we're trying to do, and quite simply, is let the physician figure out what questions he and their patient need answers. And based on that, try to understand which tests might best answer their questions. Once they figure out what they want to ask and what answers they're looking for, they can then use the appropriate use criteria to help decide, is this really the best test for their patients? Equally important, though, is how they utilize the results of the test. And based on the test, is further referral needed? Is coronary angiography needed? Now, the appropriate use criterion also exists for diagnostic angiography and coronary revascularization. So are the results of the non-invasive tests, such as an MPI, used appropriately to make decisions on when to intervene on the patient? We want to make it easy for the patient and the clinician to move forward in a very patient-centered way to get the best possible care that they need.
It sounds like a lot of advances have been made in both understanding and utilizing the appropriate use criteria. I think one of the goals of this series of interviews, as well as the cases that are being put together for Refer Wisely, are to continue to educate referring providers and make sure that we all have a similar knowledge base going forward with the appropriate use criteria. Dr. Walensky, thank you for giving your perspective on the history of the value of myocardial perfusion imaging as well as utilization of appropriate use criteria. And we'll continue the discussion on subsequent interviews.
Thank you very much, Larry.